Use of the pectoralis minor and coracoacromial ligament for chronic AC joint reconstruction with and without distal clavicle resection, the PECCAL technique. This is a left side chronic injury. The patient is placed in the V-chair position, and through a small deltoid split just above the coracoid process, we identify the medial structure attached to it. We need to identify the interval between the pectoralis minor and the medial coracoclavicular ligament. And by using a curved blunt dissector, a swab thread is passed from posterior to anterior through this interval below the insertion of the pectoralis minor. By pulling this thread, you can safely expose the muscle fibers in order to detach it from the tendon by using a tooth forceps in what we call the picking technique. Finally, the graft is tubularized using a number 2 fiber loop. The coracoacromial ligament is also detached from the coracoid side and prepared using a number 2 fiber wire in a Krakow fashion. Here you can see the final preparation of both grafts for later use. Then we switch to the clavicular side by putting a Hohmann in the posterior cortex. After identifying the AC joint line, we select the position of the clavicular tunnels. The blue ones for passing a fiber tail loop coming from below the coracoid, and the green one to receive the pec minor transfer. So, at the end, we're going to maintain reduction using this transclavicular fiber tape plus a periclavicular one, both coming from below the coracoid, in order to fix the transfer without excessive tension. So we proceed by placing the fiber tape loops. First, the periclavicular one, going from the posterior cortex of the clavicle down to below the coracoid from medial to lateral and up, and then the transclavicular one, going through the medial tunnel down to below the coracoid from medial to lateral and up through the lateral tunnel. A nice knot is prepared in each loop, but not tied yet until reduction is achieved. And then a 4 mm tunnel to receive the pec minor is drilled in between, maintaining proper distance to avoid fractures. We proceed to prepare the distal clavicle when needed by resecting 1 cm and permeating the canal to receive the CAL ligament later. It can be done through the same approach or an accessory one depending on the elasticity of the skin. After preparation, the sutures coming from the CAL ligament are passed below the deltoid muscle onto the clavicle, and the proper excursion is checked. The pec minor graft is also retrieved through the 4 mm tunnel, and the graft tension is checked. AC joint reduction is achieved by manual compression and controlled by fluoroscopy. Then we proceed to tie the fiber loops implants one by one, trying to share the loads. We check again under fluoroscopy, and if reduction is satisfactory, we proceed to fix the pec minor transfer using a cortical bottom. It's very important to check for the correct tensioning of the graft, since you may need to enlarge the inferior clavicle cortex. Here you can see both fiber loops maintaining fixation, and the bottom where the pec minor is fixed. The coracoacromial ligament is fixed in a similar manner, passing through the endomedullary canal of the clavicle and fixed in the posterior superior cortex. Here you can see the postoperative X-ray and a cadaveric model showing the correct position of the implants and both of the transfer highlighting colors. In cases without distal clavicle resection, you need to make sure that the CAL ligament passes below the deltoid muscle, so you can fix it using a knotless anchor from posterior to anterior. Here you can see the postoperative X-ray and a cadaveric model showing the position of the transfers. You can choose each technique depending on quality of reduction and the AC joint pathology. This was use of the pectoralis minor and coracoacromial ligament for AC joint reconstruction, the PECCAL technique.